Well, good evening, everyone. I want to thank you all for joining us tonight on this blustery, cold winter evening. We're really happy to have Katie Houle and Megan Mitchell, who are in the program directors for the North Dakota System of Care grant through the Behavioral Health Unit. And it's a fairly new grant, and I'll let them talk about that in a minute, but it's been really nice to collaborate with Megan and Katie and work towards some mental health systems in the state that are going to work for everybody. So I'm really excited that they have this grant opportunity, and I'm just going to let them go ahead and take over.
Well, sounds good. Well, thank you so much, Janine, for having us and setting this up. And thank you for all of you for being here. I know you're probably very busy with your home life, snuggling up at home tonight. So we appreciate you spending a little time with us. So once again, my name is Katie Houle. My title within Department of Health and Human Services is as a clinical administrator, specifically for our System of Care grant. And so we sit within our behavioral health division's policy team. And so, just a little background, our behavioral health division is made up of policy and programs within DHHS, but we're also thinking about what we used to call our field services, but our services that are served within our human service centers. So, Megan and I don't sit within a human service center, but we certainly think about policies and programs that are delivered through our human service centers and well beyond that, which we're excited to share with you. Um, I'm based in Bismarck. I'm a transplant to North Dakota. I'm in my 5th year and loving every moment. I married into the state, so I'm really happy to be here and doing this important work. So I'll have Megan introduce herself too.
So, hi everyone. I am Megan Mitchell. I am working very close with Katie on the System of Care grant, and my title is actually the lead family administrator. So, I always tell people, long story short, my role is really to get that youth and family voice heard. And so, that's part of the reason why we're here tonight is to explain to you what the System of Care grant is. But also, we really want to be working in partnership and hearing from parents and caregivers across the state. I am someone that's born and raised in North Dakota, so I definitely have a passion for North Dakota and the services that are provided throughout the state. And I am based actually out of Cavalier County, so up by the Canadian border. So that's just a little bit about me. So we are excited to be here tonight.
Perfect. Thanks, Megan. So, our goals tonight, with our little bit of time together, is really to provide a safe, inclusive, and relaxed space. So, a relaxed space for us to really allow you to share your perspective and experience in navigating the behavioral health system. We are really
Hi.
hopeful to
Hold on.
utilize
I
feedback,
don't have any sound.
not only tonight, but in the future around strengths and barriers within our system. And we're really hopeful as well to lay a foundation for you to develop a relationship with Megan and I. I think oftentimes, especially when we're navigating really tough and difficult situations, we're really trying to navigate through a system that can be really complex at times. And we don't always know the people that have impact, influence in this work. And so we want you to know who we are and to know how to work with us and how to communicate with us and how we can reach out to you to better understand your needs and impact changes within the system. We don't take relationships and trust for granted, right? And so some of the things that we'll talk about in terms of really critical gaps and really important opportunities for change can be challenging and triggering, right? These are going to remind you of things that you have endured personally. Um, whether it be yourself or on behalf of your children or people that you love and care about in your community. And so we want this to be just a stepping stone in developing those trusting relationships with you. And then at the end of this, we want to offer additional opportunities for engaging with us. Speaking in a group is not always preferred for everyone. So, would it be a good opportunity for us to be connecting with you individually, or thinking outside of the box of ways that we can share your perspective with policymakers and leaders in this work to make sure that all of what we're doing within system of care is youth and family driven. So our agenda, as I shared, I'm going to provide a brief overview of the System of Care Grant Initiative. So really talking high level, what is System of Care, and what is the impact that we're hoping to make within our local communities, our regions and state. I'm going to update you a little bit on what those current priority areas are, where we are looking at supporting with funding to lift specific services. And then a bulk of our time together is I want to listen and learn from you. So we're going to have a time in which Megan is going to moderate and for you to share a little bit about your experience that can impact our work. And then as we have time, we will hopefully be able to answer questions. I think tonight this is a small enough group that maybe we could even have some informal discussion, or answer questions that you have about some of our systems work. So, really just diving in. So, the System of Care grant is a federal SAMHSA grant. SAMHSA is Substance Abuse and Mental Health Services Administration. And it's really our federal government body that provides needed support and funding to really focus on behavioral health conditions. So, both mental health conditions as well as substance use disorders. The purpose of the grant is to really utilize funding to build a much more robust and comprehensive continuum of care for children's behavioral health services. And so, when we think about robust, what we're really looking at is in a lot of communities right now, even our more urban and populous centers, we have really big gaps between our outpatient services into our hospitalizations. So we have really significant gaps in need for intensive home and community-based services. And the focus, sort of the population of focus for that is really looking at how do we create those strong continuums for children, adolescents, and young adults, specifically birth through age 21. That's our grant requirement, looking all the way from early childhood all the way into their more sort of transitional age youth, 18 through 21. We were one of 6 states that was awarded $3 million per year between 2022 to 2026. It was part of our grant requirements at the state is to really initially, as we're thinking about system of care and how we're going to lift these services and create cross-system partnerships, is to look at 2 key geographic catchment areas in the state. So you can see that map on your screen. We're looking at the area that is served by West Central Human Service Center, so the greater Bismarck-Mandan region, which includes the rural surrounding counties up into MHA Nation and down into Standing Rock. And we're also focused on the region that is served by Lake Region Human Service Center, including Spirit Lake and Turtle Mountain, and stretching into Cavalier County up in the Northeast. To get ahead of questions, maybe one of the questions you might have is, why aren't you thinking and focusing about my region? Um, and the thing that I'd like to say is some of the work that we're doing and thinking about policy and funding is going to have great impact and reverberations around the state. But we really wanted to ensure that the work that we could do was sustainable, and we needed to really focus on 2 key regions to think about what can be piloted in these regions and how can the challenges and the barriers we experience, as well as the successes and really strong outcomes really impact how we spread this throughout the state. And so those are what we're focusing on between 2022 and 2026. But certainly anything that we're doing around system of care is hopefully going to impact other parts of the state. So the first goal of the grant is really for us to increase access to high quality and culturally appropriate services and supports. I really like this circle on the right-hand side. I think a lot of times what we're seeing within our system right now is we're seeing really big gaps, or what we describe sometimes as silos, right? If we're thinking about silos on a farm, we're thinking about our social and child welfare services and the gaps between those and our healthcare and mental health systems. We're seeing big gaps between those services and juvenile justice, and also thinking about transitional services, the transitional services from childhood to adulthood, and those services in our early childhood. And so we really need to focus on not only what are the services and supports that need to be lifted, but how are we making sure that those are all all connecting and becoming much more coordinated and streamlined for the children and families that we serve. The services that I've listed there are some areas of focus that SAMHSA wants us to be thinking about and looking at in North Dakota and those specific regions. But I would say we're primarily looking at not thinking about inpatient hospitalization beds or residential beds, but thinking about what are those intensive and home and community-based services that we can be implementing as close to home as possible, and how do we do so from a very youth and family-driven perspective. We have to be thinking about local and regional and state culture as well. So, how do we create the services in the community, but how do we localize them? How do we think about really critical issues of stigma and barriers of transportation and poverty and food insecurity? So, we have to think about the services that are needed, but how do we minimize the barriers that we have in accessing those services for children, youth, and families? So, with that in mind, our second goal of the North Dakota System of Care grant is to develop a sustainable infrastructure to support system of care. And when we think about infrastructure, and I'll be honest with you guys, the word infrastructure, I haven't been thinking about infrastructure for a long time because a lot of my background is in direct care. I've been sitting with children and families in hospitals and really thinking about how do I navigate from this level of care into the next? How do I make sure that there's a safety net? But infrastructure for these large grant initiatives is really thinking about what are the partnerships and relationships that have led us to be really separated and siloed in our work? And what are the policies and funding structures that we as a state and as a Department of Health and Human Services, how do we create those partnerships so that the children and families that are living with complex behavioral health needs and navigating those systems are not the most impacted? And so, along with lifting those services, is how do we create coordinated referral pathways, and how do we integrate trauma informed and recovery oriented care elements throughout that project? So, when we think about trauma and we think about not only interpersonal trauma and the traumas that exist within sort of an oppressive system, or the traumas that exist when experiencing poverty or being unhoused and so on, but how do we also deepen that understanding of how historical trauma has existed within our state, and how do we ensure that we're integrating that into the services that we're delivering? How do we in our work promote and sustain family and youth engagement within system of care? So not only thinking about how do we sit here with you all and understand your perspective and story, but how do we ensure that beyond involvement and engagement, we ensure that this work feels and is really driven by individuals with lived experience. And also, I won't bore you with some of the infrastructure things, but we're thinking about, just as a division, how do we actually develop some of the governance structures that is needed to sustain this work for the long term. I know that I've experienced firsthand, and this may ring true for others, but the last thing that we want to do is start services, get connected with youth and families, see strong positive outcomes, and have those services and partnerships disappear or go away when funding ends. And so that's going to be a critical piece of not only developing trust between our system entities and those, all of you and those with lived experience. But it's going to be really critical for us to be maintaining those so that we're building on those relationships between those child serving entities, between behavioral health and schools and juvenile justice and child welfare and so on. So what is a system of care? A system of care is a spectrum of effective community-based services and supports for children and youth with or at risk for mental health or other challenges in their families. And those core parts of a system of care is that it's organized into a coordinated network. It builds meaningful partnerships with families and youth and addresses cultural and linguistic needs. And so the primary goal of creating a strong and sustainable system of care within North Dakota is really to help families function better at home, in school, in the community, and throughout life. And I think one of the conversations that we've had that really is an indication of, I'll just say it, a deeply broken system is we are seeing significant patterns of juvenile justice and child welfare really being the gateway to treatment, right? So children and adolescents and young adults are having externalized behaviors that we all know are both age appropriate and appropriate based on histories of trauma and significant behavioral health and substance use diagnoses. But we are not treating them and supporting and connecting. We are citing and really delivering to children and families the message that we're not listening to your need. We're citing and we're getting you into treatment or sending you on sort of a wild goose chase to find the treatment and support services that you need. That's not coming from my perspective. That's just what we've been hearing, and I'd be interested to hear your all's perspective as well. So the system of care values are really, how do we deliver services and support that are community-based, youth and family driven, and culturally and linguistically responsive. And so what we're thinking about through system of care is, on a system level, how do we strengthen the collective voice of youth, parents, and natural supports? So how do we strengthen your voice individually, but how do we partner with important organizations like Family Voices and Deneen, right? Family Voices and other family-run organizations exist to make sure that your needs and the collective voice of youth and parents are being heard at many levels. And at a service level is, how do we ensure that service planning, it centers the vision and values of the child and family? So it's not about what a clinician believes needs to be part of your healing and treatment journey, but what is the child's vision? What is the family's vision of wellness? And how can professional and natural supports get that child and family there? So a quick update in terms of really milestones and priorities. We have been really investing in cross-system partnerships. And the reason being is we really want to develop shared accountability and responsibility and trust among those really core child serving entities I shared. So our human service centers, our private behavioral health providers, our schools, our juvenile justice and child welfare entities, and our family-run organizations and other entities that serve children. We've convened regional steering committees that are helping to prioritize and guide implementation in those two regions. And we've been setting up a data infrastructure at the Human Service Centers to really understand who are we serving, which is going to help us understand how can we serve them better. And then the services that we've been really focusing on is we did release funding specifically in those two regions to focus on intensive day treatment and partial hospitalization programs. So when we talk about partial hospitalization, we're thinking about an intensive time limited treatment program that really functions like a day program. So a time that a child or adolescent can go to treatment from 8 to 4, similar to they would go to school, but during the day they're integrating school and therapeutic interventions, individual, family, and group interventions, as well as psychiatric care. We've been looking at our mobile crisis continuum and really thinking about how can we create a safe place to be, whether that's in stabilization in the home and in the community, or a place outside of an emergency room where a child and family can seek resources, and to ensure that law enforcement are not the ones that are responding to mental health crisis. We're looking at parent and caregiver peer support. So thinking about, we have peer supports in our behavioral health system that are really thinking about adults with mental health and substance use disorders, but we would really love to create opportunities for parents and caregivers with lived experience of navigating the system on behalf of a child, to be supporting other parents, and that to be professionalized and reimbursed, and supported with funding. And we've also been looking quite a bit at substance use treatment. We have significant gaps in our system for child and adolescent substance use treatment. We have residential programming, we have programming through our human service centers, but the access to outpatient, intensive outpatient programming is very limited to no services in most parts of our state, which is pretty critical. And that's what I wanted to share. There's so much more I could share, but I don't want to take up time tonight only focusing on what we're thinking about, what we're doing, because the purpose of us connecting with you all is for you to know what's going on, but also to hear from you, whether it's sharing something really positive that has existed in your community that you want to make sure that we integrate into our service array, or something that's been really lacking for you professionally, personally, or within your family, that you think should be a key priority for us. And we're here to listen. And like I said, because there's a small group of us, um, if you all want to share, or we could have some informal discussion, we'd really appreciate your perspective.
Anybody want to start? Vicky?
Okay, I'll start. So I had a question about your release of those fundings to partial hospitalization program. When you were looking at the program, is it truly, do you have to have a dual diagnosis?
So you do not. So the way that we set up the funding is so it's open right now, Vicky.
Yep.
So we don't know, but the way we wrote it is so that we could provide the funding to a hospital-based partial hospitalization program. And a hospital-based PHP typically would be for mental health or co-occurring disorders. And then we also release the funding for community-based partial hospitalization program, which would typically be a licensed substance use disorder provider that is licensed for child and adolescent partial hospitalization.
Okay.
And the reason is, Vicky, is that based on Medicaid guidelines, the hospital-based program has to be overseen 24 hours a day by a physician. And so that is going to be the added psychiatric component to that program and its connection with a hospital. Do you have any feedback on that? Things that we should be thinking about?
Well, just part of it, long time ago, we used to have partial hospitalization. And then they kind of went away from it and it's just coming back in. But I find with like a lot of the families I'm dealing with in their youth, like they always say, well, okay, they have a behavioral health problem, but they don't have a drug abuse program. So we can't offer this for them and we can't offer that for them. So I'm really just trying to, because I mean, you're going to run into kids with those major behavioral mental health issues. A lot of them stem, right into the family because the family alone has mental and behavioral health issues. I guess when I had contacted CHI for that, because that's the one you have right now, right?
Well, it's actually not open. They don't even have the adult partial right now. So
No,
there's no,
but
yeah.
But there was a contact number.
Okay.
So I just wanted to see because it's actually on their website. So I mean, if somebody called, okay, so Katie, I was doing a cold call to see what happens if somebody actually called that.
Oh, that's good.
And
Okay.
they were very, I mean, they were nice. Whoever I spoke to was nice. Okay. But it was like, oh, this whole program is for substance abuse only. So, I mean, if it's substance abuse only, not saying that we don't need those programs, but the mental health, that I work with, at least the families I work with, and most of them are connected to the education. And our education system is failing. I mean, you couldn't talk to a parent probably in the state with a child who has a behavioral health issue that can actually say that school is going terrific. Some do okay, but it's difficult. And I understand because there's so much behavioral health. There's the diagnostics and the med management, and there's so much going around with that. So that's where I was kind of looking at the system of care. Is it just, are we doing something again that just focuses on one thing? Or are we really encompassing the whole family portion of it again? Are we getting back to wraparound services?
Is it okay, Janine, if in a larger group, the question and respond? So my response to you, Vicky, is that we need to be looking at specific service gaps that exist within our service array. We want to look at step up and step down services. The second part of that is, if we have really good evidence-based services, we also need an intensive care coordination model that is really, and transitional services that allows a family to be able to navigate that system, especially if they have significant, severe, and complex behavioral health conditions. So when Vicky talks about the wraparound model, that's really thinking about what we know about children. And I'm just going to say children. They could be your children, our children. What we know about our children with complex behavioral health conditions is that there's a lot of multi-systemic involvement, right? There's a psychiatrist, there's an outpatient therapist. Maybe they are or are not. Maybe Vicky's helping them get on an IEP within their school system. There's a lot of professionals that are engaged and involved. And in an intensive care coordination model like wraparound the idea would be is having one entity that's really responsible to bring all of those professionals to the table and follow the same plan for that child and family, instead of putting the burden on the family or the caretaker to say, I have to tell my story to 7, 8 different people in a week. and I have to tell the plan that the psychiatrist made to the school and so on. So I just wanted to give that background because, Vicki, I know that you're deeply knowledgeable about this, but just in case other people haven't thought about that wraparound method. So Vicki, we are, as part of the System of Care Initiative, we are working to develop a relationship with the National Wraparound Implementation Center. So we are looking at reinitiating a high fidelity wraparound model. I don't know where in that system yet it will be.
Yeah, and that's good, you know, and then I'll let somebody else go. And one more thing I have for you, since, you know, you're talking about creating all these entities, we're making the top, looking at that care coordination piece, you know, like a medical home piece would be there. Are you finding when you're talking to professionals about your system of care that they're buying into this program, like, or buying into the philosophy of this program? Because there's going to be, like you said, so many people involved. And then all people hear is like parents here right now, well, I can't get you in for this, can't get you in for this, because it's 9 months to get in to see a psychiatrist. If you're lucky, maybe a year and a half. Pediatric neurology could be 2 years, a wait list to see those professionals that would be involved in your system of care.
I would
Yes
say
or- Yep. You understand what I'm getting at, like, maybe, or maybe I'm saying that wrong, Katie.
I think so. Let me answer it and see if I can answer it correctly. I would say, first of all, it's been easy to get people around system of care because the core values of creating a community-based system that's easy to access for youth and families really benefits professionals as well, right? Professionals, I'll just say from my experience, I did a lot of discharge planning from inpatient psychiatry. And so as a professional, I was trying to navigate the system on behalf of children and families, and I found it difficult and very complex. So I say, Vicki, there's a lot of people that are willing to be at the table and to talk about and help define the problem. I think the challenge will be is getting support from the local, regional, and state level to really adopt this value and philosophy as an entire state, right? So it's in order for us to change the system, all of those systems are going to have to be willing to change, right? So we're going to have to create partnerships between all of those areas and be joined in those philosophies. If it's okay, Vicki, for me to give you a classic example of that and just see if it connects with anyone else in the room is
Right.
one of the problems that we're seeing in our system is that children that get involved in the juvenile justice system are being cited and mandated to treatment, but there aren't treatment providers, or the treatment providers that they're being mandated to do are really functioning much more from like a recovery oriented harm reduction. Let's really engage with this child and see where they are in terms of their stage of change. And the juvenile justice system is accountability, accountability, accountability. So there isn't actually any joint effort, communication, and collaboration between behavioral health and juvenile justice to say, let's sit on the same team together. And of course, think about public safety and accountability and all of those things, but come at this from a much more trauma informed. Why is this child becoming aggressive in the classroom, right? We need to be assessing this from a much more sort of trauma informed and responsive way. But that is going to require both the behavioral health system and the juvenile justice system at a policy and a program level to really change, adjust, and weave together. And so I would say, Vicki, I feel really hopeful and positive about these relationships and getting the right people to the table. Change is going to take time as it relates to, changing policies and funding structures and things like that.
Perfect. That was a great example. Thanks so much, Katie.
So I guess to piggyback off of like what Vicki and you are saying exactly, Katie, is to kind of go that I guess I fall in the cracks of like who would qualify for system of care? Because I think I fall in the cracks that I don't have the autism waiver, I don't have DD, so ADHD doesn't fall in any of that. At the school, like Vicky says, is very lacking and completely broken. And so when there's problems at school, and yet I have the psychiatrist, doing everything that they can, and I'm sure all of us know that ADHD has very addictive behaviors, and so I don't want him to get into the justice system, and I'm trying to do everything on my part not to get him into the justice system. So like there are no intensive, and so the psychiatrist wants intensive in-home based services, but there's nothing out there. That's where like I am at, that how do I get any services? Because ADHD has no services. I feel I have no case management, no services other than a psychiatrist.
So I would say, Melissa, system of care is not a specific program or service, but system of care is exactly for you, meaning what we need to do with this grant funding and the larger initiative is actually create the service lines for intensive home and community-based services for you to feel much more well supported beyond your psychiatrist, right? And it's not about diagnosis and condition, it's really about what are the impacts of that diagnosis on your child's sense of self and relationships with family and ability to attend school and do well in school and connect with peers? I think what system of care is for is to not only start the services that are needed for case management and treatment, but also help you to navigate those things if and when there is a point of crisis, right? And that's what I mean, Melissa, in terms of we need to flip the system on its head of we don't want your child to get into juvenile justice and that be the point that they receive the intensity of treatment that is needed. To have them thrive at home and in the community. And I would say we are certainly not there yet, and we have a lot of work to do. And we're really hopeful that the System of Care grant can really help reinvigorate and intensify the need for this work. Where are you open to sharing what region you're based in?
I'm 7.
Okay.
And anytime like there's something, we have a behavior at school, and then, okay, can the social worker work with him? Oh no, the social worker doesn't do that. Okay, but it's a behavior at school. Like,
Okay.
Yeah, I think, this is just Vicky again. I think what I hear the most from families, Katie and Megan, it's kind of like, yeah, I mean, they're turning corners and everybody's trying to put that job on somebody else, like, oh, we don't do this, so call here. And then the people you call, they tell you to call somebody else. So, it just kind of goes down the line. And I think most families experience that. But I get really highly concerned when I have a few parents call me and they say, well, my son entered into the justice system, but at least he could see somebody then. That is not a philosophy that anyone wants to hear. But they're hearing it from different places. And so when I'm hearing that from them, like you said, I mean, you were nice enough to admit that we have a broken system. We should never have to have a child be processed in justice to get any kind of sort of family help of some kind, support, respite, all those services like you listed. So that's not really a question. That's probably me telling you that's what scares me the most.
I appreciate that. Thanks, Vicki.
I know, Katie, when you said some of the good things, I was very excited to hear when MST had started their trial or their you know, and I thought maybe it would have spread out, and it never did. It stayed in the Fargo area. I've had a few kids use that when I've had youth over in that area, and I like MST. I think that's helpful. I've recently started working with youth on the spectrum, and they are highly intelligent autistic youth. And it's very difficult for those youth. They don't qualify for DD services, you know, and they appear oppositional. So, their mental health is being, kind of is criminalized in that way. But it's hard to find services. You're getting turned down left and right by everybody. Like they said, try this, try that. And it's frustrating for the parents before they even came to us, or the youth came to us. So I think there's a lacking for autistic youth in our state.
Corey, are you open to sharing what MST is with the group, just in case anyone's not familiar?
Multi-systemic therapy. They have a team that works with the families, and then they're through the Human Service Center over there. And there's a group of them that, they work with the families really closely, come into the home. And they do, it's almost like another case management for the families. It's probably not the best way. Another support for the families that they come in and help with, do therapies with them, things like that, behavioral therapy, the families, family therapy and all that. So work on safety planning in the homes.
Yeah, MST is a very intensive home therapeutic intervention with 24-hour care essentially as needed. And 24-hour care is really critical when having a team, is because when you're calling for help, it's a team and a collection of people that you know and have developed relationships with, as opposed to someone, whether it be law enforcement or a crisis team. So that is something that's been within the Fargo Human Service Center, and certainly something that we've thought about with system of care, of needing that level of intensity to being in the home for those youth. So I appreciate that. Thanks, Corey.
Katie, it looks like in the chat, Carrie had shared, and I'll just read this word for word. I believe the juvenile justice system in schools would fully support a crisis residential unit, mental health, behavioral health, substance, and trauma that has intensive care coordination wraparound with local services. Sorry, I have to just scroll down. Local services and natural supports in those regions close to home. It would keep youth out of the juvenile justice system. So juvenile justice could focus on public safety. It would allow schools to focus more on education, and school and juvenile justice could be supports, but not driver of that care coordination.
Thank
Carrie,
you, Carrie.
yeah, thank you for sharing that, Carrie. I think you definitely bring up a good point. I know it's something other people have shared, but I think one thing that Katie and I keep coming back to and hearing from other people across the state is that in order for kids to get services, why do they have to go into that juvenile justice system? And why can't we look at other supports that could be helpful to them? So thank you so much for sharing that. Margot, I saw that you had taken yourself off mute and then you're on mute. Did you have something that you wanted to share?
Oh, okay. Can you hear me now?
Yes.
Oh, okay, great. Well, I'm in the Fargo-Moorhead area, and I've had families that have needed and wanted to access Prairie St. John's for day treatment or inpatient hospitalization, and the kids badly need it, and the parents are really hesitant because they can't afford it. And I have contacted Prairie St. John's towards the end of last year. I haven't asked that question directly, really super recently, but they haven't had any other funds to help support that if a child's not on Medicaid or if the family doesn't have really good insurance. They're stuck. They can't, access what's needed for those kids, even though they're really in bad shape. And you said something about with the funding, Katie, that your funds are going towards some day treatment. Can you talk about that? And also, there's just not enough places for families to access help for their kids like that. But can you talk about the funding for that? Is there some hidden pot of fund money I don't know about that we can help these families with?
Well, I don't know about the hidden pot. And I think the thing that I would say about that, Margot, and I'll answer your other question, is we certainly have to acknowledge that the fee-for-service model for Medicaid and commercial insurance is really limiting for those that have the most complex and severe need, right? And that's really the disconnect. Is we're seeing that providers don't want to start those services because they need to open their doors and turn on their lights and pay for benefits and staffing and all of those things, but they're not able to do that with current reimbursement rates. And so what that means for our system is we don't have the services that are needed, even if they are reimbursable. But how do we pay for the services that are there if a child is un or underinsured in some capacity? I don't know of a pocket of money, Margot, besides like the SUD voucher used for those 14 and above to seek substance use treatment, disorder treatment. It is something that we've thought about with the System of Care grant. Is could we create like a voucher system or a waiver system that we see in other parts of how do we pay for the services that are needed for children that need them now, and we develop the sustainability around it. I guess the problem with that is it's sort of like, I don't know, like we need to build the house, right? We need to build the house that these services and supports can live in and exist in. And so that we can be delivering these services for the long term. But it's certainly something that we've thought about, especially in the human service centers, is how do we make sure that someone walks in the door and if they need help, they're given help, no questions asked. I don't know if and how and when we're going to do that, if I'm being just candid and honest. The second part is we just released in our in our procurement system, Margot, is a request for proposals. So we've basically put something out there in the last week that says we have this amount of money. We want to support an intensive day treatment model or partial hospitalization program within Bismarck, Mandan, or the greater Devils Lake region. And we're open to accepting proposals on that. So really right now is we don't have intensive day treatment services. And we are trying to incentivize or motivate a private entity to do that. What is the risk in that? Is money could go out there and no one picks it up. No one wants to do that level of programming, but we do feel really confident, especially in Bismarck, Mandan, that we have the partners and infrastructure in place. In Fargo, where you're sitting, yeah, Prairie St. John and Sanford Health both have a child and adolescent partial hospitalization program, but we don't have those in any other parts of the state. I don't know if I heard a rumor that Trinity closed theirs down. Maybe you guys know better than I. Is that accurate at all? The child and adolescent partial hospitalization program in Minot?
It's closed.
So that is a big hit to our system as well. if we develop a waiver and voucher system, especially things that can support treatment and respite and caregiver support, we will be sending information out through Deneen and others to make sure all of you that are doing this work have that information. But I don't have the answers for that right now, Margot.
Just know that it's a real barrier. And that's pretty sad. Yeah. And then of course, Sanford Health, their partial hospitalization and hospitalization program only go, I think 14 and up. So, then that brings us just to Perry St. John's. Not to mention people having bad experiences with one provider, and that's the only provider. When that's worse, I see what you're saying with these other communities that don't have anything. Yeah. And this may be a little off the topic, but like Children's Health Services for the state of North Dakota, you know, is another way of accessing some funding for some of these kids with needs, medical needs. And I haven't talked to them for a couple of months, and I know that the list of the conditions are looked at in May, usually yearly. But as far as mental health, ADHD was the only condition the last time I checked that is covered, you know, where for somebody without insurance, that might be a great resource, you know, for funding some therapies and different things like that for ADHD. But things like autism and other types of mental health things aren't covered because it's, I don't know, too expansive. Is that anything that you guys look at?
Well, it's really meant to consider across systems. So if we think about a complex, you know, behavioral health condition with an intellectual or developmental disability and a special healthcare need, I guess our North Star, Margot, would be that we would have a system that really allows and aligns all of those complex needs and creates a really centralized service and treatment plan that integrates those things. So it's certainly a part of the conversation. I think right now it's really about us creating those relationships and creating those cross-system strategic plans with developmental disabilities administration and you know the healthcare side to figure out how can we be doing this work together, because along with there being gaps in the system, there's a lot of redundancy too, right? When we think about challenges in workforce and make sure that there are people that are doing this work is how can we be changing our human services workforce in a way that is more efficient and effective, of thinking not only about the fact that a child has an autism diagnosis and pediatric diabetes and challenges around you know, impulsivity or whatever that behavioral health condition may be, is how do we think about those things together, because we know they are interconnected, right? Like how someone is showing up physically in the world and mentally and spiritually in the world are really integrated and interconnected. I think one of the challenges and fears I have as being a director of this work is I talk a lot about the ideal system, and we really need to follow that up with action and implementation, right? Margot, you might be like, sounds great, Katie. Sounds like the perfect plan, the North Star, that's what we need. But how are we going to be doing that incrementally and in a way that actually we're seeing impact in our system? And so that's really our goal. Those are our next steps, right? To really sort of believe this work. It's not only believing in me or in Megan, it has really nothing to do with us. We're stewards of this work. We need to put the right partners at the table. And so I do think that that comes back to some of our steering committee work is how do we make sure that those steering committees are inclusive and reflective of the diversity, both professionally and individually with lived experience of those within our region. So for those that are doing this work, especially in those regions, we'd really encourage you to reach out to us and see if you want to engage in those committees, because we actually want those to be specific and solution focused. We're developing real-time solutions in the moment to these key system problems. And then we need to do that on a much larger level in terms of our, executive leadership and policy. So going back to sort of what Vicki shared is, in a lot of ways, it's not hard to inspire and motivate because there's actually a lot of connection and alignment across the system of what is wanted. There's a lot of focus on, the health and safety and the well-being and really the thriving of children, adolescents, and families. But we're not delivering on that, right? We're not following up with those action points. And so we have a lot of work to do in terms of being action and solution focused and redeveloping trust that we're moving in that right direction on the behalf of children and families. So I just want to acknowledge and recognize that sometimes it feels like this hopeful dream, but I want you all to know what we're working on and why.
Oh, and we appreciate that. Absolutely. That there's the brains working on it that have been in the field, trying to do discharge planning and help, families and children that need this. So no, that it's appreciated. And then one last little comment, I just have to voice it. I think a lot of us know this, but I just think there's so many parents, families that are exhausted, trying to help, get help for their kids. And like you mentioned, Katie, it can be confusing for a professional that's a discharge planning, how do we access all the things this kid needs and keep them going or whatever. So it sure needed the parent support to coordinate these and access. But then, and I just so appreciate families and parents that are open. And there's so many families that are open for help and just really willing to just kind of bare their souls and share what they've got going on. But then there's also that fear of, boy, if everybody knows everything about my family, that's kind of scary too. So I love the wraparound process, but it's also, I think, one that a person really has to be courageous to step right into as a family.
Mm-hmm.
Well, one of the things I like about the wraparound process is the focus on engagement, right?
Mm-hmm.
It's not about one meeting. It's about consistency and showing up and being a part of that process for 6, 7, or 8 weeks. It's about relationships, right? And I think ultimately that's an important piece of treatment and support work. So,
Yes.
Roxanne, I saw you had a hand up.
You're on mute, Roxanne.
Yep, I got it. Thanks, Janine.
Mhm.
I'm curious, as part of the work, are you looking at the workforce and doing any work with higher ed? The level of intentionality that has to happen with this case management is so critical. And I think, obviously you always have to consider caseload numbers on this. If I look at the DD system right now, that's part of, I think, one of the problems is the caseloads are incredibly high. And so it leads then to less of that family and consumer engagement. And I know that we have, every conversation you're in is workforce shortage, but the kind of level of intentionality that you're talking about for care coordination or case management, I think is, I don't know that we necessarily get that out of a new grad, right? So I'm just curious if the system of Care Grant is partnering with higher ed. If you're partnering with higher ed, what you might be doing to address the workforce issue.
I really appreciate that. And I was a wraparound facilitator out in Washington State. And so Roxanne, I think far too much about caseload ratios than the average person. Really for complex behavioral health conditions, the caseloads should really be about 1 to 10 or 1 to 12 at maximum, right? And the goal of that, right, is because the level of intensity, the preparation for crisis, the ability to build trusting relationships and connect the fact that a lot of times there's mental health and substance use disorders and issues that are happening within the home that have nothing to do with the child or are very interconnected with that. And so the answer is we have not directly made connection between system of care and higher education, but system of care and the work that we're doing around workforce development and training to specifically provide services to this population are really integrated in some work that the Behavioral Health Division is doing. There's a ton of focus right now throughout divisions, whether it's teacher recruitment and retention or the behavioral health workforce around. And so there are connections with higher education as well as like our state licensing boards, social work and marriage and family counseling, psychology, and so on. But that is, I would say, a critical component. And Roxanne, I think a part of that too is connections with higher education, but also connections with higher education, especially in our rural and tribal communities as well. Our tribal communities are sharing with us that there are people that are very viable champion community members that could be a part of our human service workforce, but they're not taking their licensure exams. They're not really sort of tapping into that infrastructure and workforce development and training for lots of different reasons, right? We can't go into historical trauma and colonialism with the time at 902, but we need to be creative and innovative in terms of how we do that. The thing that I would leave you on is we do have to think about this from a tiered perspective, sort of more of a public health pyramid perspective. Is high fidelity wraparound and intensive care coordination could really be thought of as something that's utilized for the top 8 to 12%, or the 8 to 12% of children and families that require that intensity of service. And then we would think about a tiered approach. What are the ratios and modalities that are used for those that are, moderate to high risk? And what are those like universal opportunities for engagement within system of care work for all children? And so I think if we think about it from a tiered approach, is we can't have intensive care coordinators for all children, but how do we make sure that we're reaching the children that need it, which will really alleviate and allow our system to really focus on the more moderate to high risk as well. But I apologize, that's my long answer to that.
No, and I'm just going to add that kind of work requires, I think, a great deal of reflective supervision and professional development. So as you're building that system, if you're thinking about state TA or PD development, I think it has to be part of it. You can't just create that level of case management without that as well. And so I think sometimes we think that maybe that's the fluff and we just expect supervisors to do that, but I think it's important work. So the preschool development grant, the state just got in. So that money, it came into DHHS, into early childhood. They're focusing on the pyramid model for birth to 5. And several of the Head Start programs now, I think there are 4 in the state, are working on the pyramid model to fidelity. And that's a big piece of that, is the reflective supervision and then having that PD in place for those folks. Because I mean, Vicki needs reflective supervision and intensive support. I mean, and it sounds like there's several of you
Yeah.
on the call that do, because of the level of it, of intensity of the families and children that you're serving. Vicki, you're chuckling.
Yeah, thanks for that. Do need it.
Like when you talk about Katie about the trauma, like I know like my kids were preemies, so there was a lot of trauma there, and kind of link that back to my kids had early intervention, and so I gave the plug, like I know it's the biggest goal or dream I would ever have today. I was in Baszler's family engagement and I said, I wish every parent would have early intervention. I have a master's degree and I still came out of the hospital 3 months with a sleeping baby, but I was like, what do I do with this thing? Like, oh my goodness. And even with my oldest, 3 days after he came home, he aspirated and turned blue and I had to do CPR on him. So like if we would put early intervention in the beginning, how much money could we save? How much recidivism, like would we not have our kids in there? So let's put our money in early intervention and give every family early intervention. And that was my plug today. And I think they're all like, yes, but we can't. And I'm like, yes, we can. We wouldn't have them in the justice system. And look at how much we would save. And so I did that today, Roxanne. I said, every kid needs early intervention, every parent. So yeah, I think that saves so much is like that trauma, because the parents have trauma too that we don't know. So if we gave them early intervention, it would just, early intervention is amazing. So talk about, like you're talking about the trauma, Katie, is I had trauma having preemies. I was like,
Yeah, Melissa, I mean, I just think there's so much there. I think, not to take up too much of your time, but I mean, even thinking about early intervention, but the reality is our system has been so adult focused as it relates to mental health and substance use, right? Like, and really the ultimate prevention for having issues with functioning in the community, if you have a behavioral health or substance use disorder, is treating children. We know clinically that birth through 5 is some of the most integral time to develop attachments and sense of self. So I agree with you, Melissa, and I appreciate that perspective.
Katie, in my region, well, in my district, I should say, not even region, but we have a gal that works for PATH, but she is in the school systems, and at least 2 of them. And I know that for the education piece, I mean, by and large, she works with many kids that have a behavioral health diagnosis. It has been a really good experience, and and I wish we could get someone like her in every school in the state. I mean, for the school systems especially, I mean, we all know that behavioral needs are escalating to the nth degree in the school system, but and of course they would need more help, but I tell you, that was a really good move on our school district's part, because they are doing phenomenal work. So I just wanted to mention that too.
I appreciate that. I've heard other positive things about Nexus Paths. Yeah, like school-based care coordination, essentially, right? Okay.
Yeah.
Um,
And I see Michelle's on too. I don't know, Michelle, do you know of any other things happening in the school system that have been working real well?
That's a great question. I think from my perspective, so being at the Department of Public Instruction, I think I hear what you're saying, and I think we have administrators and that still need a little more, training and information, and we keep providing it and pushing it. From the Office of Specially Designed Services, I only have so much front, but I'm trying my best. But doing we are seeing some growth in, our state systemic improvement plan is around increasing graduation rates for students with ED. So we've been really working on, for any of those students with that social emotional behavioral, what are the evidence-based practices? How do we get early warning systems in place that can help us identify kids needing support? So we're certainly working with that. But the biggest thing that I think has helped us over the last few years is that a whole bunch of us across systems, and Katie and Megan are amazing and have been a big part of joining us and pulling us with them in this work as well, to ensure that these kids are getting those supports across systems. And I personally believe, like everything like all of you are saying today, is each group can't do this alone. We need that coordinated system working together. I taught kids with these intensive needs for 10 years, and I can tell you that until we were all working jointly together, kids weren't successful. So that's my passion, and I'll keep pushing for it. I wrote down a whole lot of things you guys have said tonight and want to dig in. I think is really interesting to hear about the Nexus Path people in schools, and I want to learn more, and I will. But I think it's taking that time to keep training and making connections and helping ensure that we are doing stuff that we have that research and evidence base behind for the kids.
Thanks.
I think we need to do more, and then we'll keep trying.
Things that I've heard, Deneen, is I would say, like, in Bismarck Public Schools, we're hearing a lot of positive outcomes and feedback around some of the integrated behavioral health work. So it's the connection of the private behavioral health providers that are delivering services within school buildings, right? So that eliminates so many barriers for children and families, whether it be time to take off work or transportation. So we're seeing, I do think that we need to take a very sort of integrated approach with behavioral health and education and do that more deeply. But we know that that integrative work is not always everything that a child with complex needs, right? Like, they might need integrative behavioral health work, they might need case management, might need crisis-based support once a month when there's issues that are going on at home. So it's, how do we weave that together, and or how do we create the intensity of services in the community to meet those needs? I just wanted to share, Megan and I are free to hang out for as long as possible, but we know people have to duck out. So I wanted to make sure that I left our contacts there on the screen. We will meet with you individually. We will meet with an entire department of people, all of the people on your teams, or all of the families that you work with. We really, while we're doing this work of focusing on services and creating those cross-system partnerships, as I mentioned, a key part of this is relationship, right? Like, how do we develop relationship and understand what an individual is experiencing, what can we pull from that, and how can we have that drive the work? We're also really open to feedback, right? What are we doing that is supporting and assisting your work, whether that's personally or professionally? And where are we not doing it well, right? Do we need to be doing something differently? And so I just wanted to make sure that we had that foundation to connect with you all. And we appreciate all the work that you're doing and your feedback. And we're here to hang out as long as needed.
I'm just gonna also let you know that this recording will also be sent to you. It'll be posted on YouTube, and then we'll put it on our website. But for everybody that registered and those that couldn't attend tonight, they'll also get a copy of what was discussed tonight too, so that if they also want to get a hold of you, Megan and Katie, that they'll be able to do that. We in February, for those that are maybe interested, we're gonna have Monica, is that right? I think so. She's in charge of the 1915I state plan. So she will be our guest speaker in February. And then also Roxanne and I are part of a collaborative with several other entities as well. And we'll be doing a round of education, extended learning calls as well. So we'll be posting those on our Family Voices listserv that comes out every Monday. So if you're not a part of that, check on our Family Voices Facebook page, and they'll be posted on there as well. So I thank you so much, Katie and Megan. Did anybody else have any comments at all?
No, thanks for doing these types of broadcasts, and I'll look forward to the 1959 state plan one.
Okay, sounds good.
Thanks. Thanks,
All right,
everybody.
thanks, everybody. Good night.
Thanks
Thank
all.
you.
Thanks, Deneen, for having us. We appreciate it so much. Take care, all.
You bet.
Mhm.